Objective. Let's talk about how to become pain-free, reclaim your health, live a happy, healthy lifestyle. It's all about quality of life, guys, right? As you get older, you notice things that were very simple or more simple before are now more difficult in a lot of cases, right? Especially when you have, joint pain, right? So it's all about quality of life, what you want to do. If you want to go, we have people say, oh, I just want to go to dinner with my wife, right? Something that seems simple like that, and you're having trouble with it, right? And then ultimately, one of our main objectives with Next Genesis is avoid as many unnecessary surgeries as humanly possible, right? What I always say is, look, there's a time and a place for everything. It's amazing that we have these options, medication, surgeries, but do we agree that they're overutilized, anybody? Agree?
Yes.
Way too much, right? It's great to have as an option, but that's when it's only when it's necessary, and they're used way too much. And the problem is, when you get these surgeries, there's no going back, right? You can't undo a knee replacement, a hip replacement, a spinal fusion. You can't undo it. They can take it out, and then it gets real messed up in there, right? There's a lot of problems. So, okay, arthritis. I think most of us suffer from arthritis. If you're over 30 years old, you have some form of arthritis, right? That's when it starts. You don't typically notice the symptoms at that point, right? This is early on. It kind of accumulates. Then when you're 50, 60, 70, that's when, okay, now I'm starting to notice those factors. One of the reasons is because your body breaks down at 30, roughly 30, 28, 32, that ballpark. Your body starts to break down quicker than it can rebuild because your stem cell count goes down, right? Arthritis is caused by two main causes, right? There's micro trauma, and that's going to be, you're a UPS driver getting in and out of the truck all day, every day. You type on a computer all day, every day. That repetitive motion, right? And then your macro trauma. That's going to be the old surfing accident, the old football accident, that type of deal, right? Anybody been there where they had a football accident and then it healed up, and in 10, 15 years, it's like, oh, that knee's killing me, or that shoulder, or anything, right? Pretty much any body part, right? So what they have in common is that with macro trauma or micro trauma, proteases accumulate in the joint space. Now, proteases are what cause arthritis and break down the cartilage. Single-handedly, that's one of the biggest factors right there that cause it. So think of them, I always say, think of them like Pac-Man, and they're getting your shoulder up, destroying it, right? Once they accumulate, then it gets worse and worse.
Once you're bone to bone, does this still work?
Depends on what degree. I'll go through all of that. But yes, we see a lot of bone on bone. That's one of the most common things one of the most common things we see. So that's that. That's the one thing we know about degeneration, because those proteases eat up the joint, is that it gets worse with time, right? And I think most of you will say, well, the arthritic knee or shoulder, back, 5 years ago is probably worse than now than it was 5 years ago, right? And then another 5 years, if you don't do something different, well, it could definitely get worse, right? Okay, medication. I think a lot of us are on more medication than you want to be, right? They had the statistics, they said for 65-year-olds in the United States, the average 65 is on 8 to 12 medications a day. That's a lot. That's crazy, isn't it? 8 to 12 a day. Because you know how it is, they give you one med, and then here you go, we now have nausea, right? So now you need this med. And then, okay, well now these two right here give me cramps, so let me take this. Next thing you know, it's like, man, I just had this one problem. Now I'm on 6, 7 different meds, right? So, it's a route that hasn't really worked out too well for us. Nobody wants to be on all those meds, right? And I'll go into some more stats in just a minute. I think they're pretty staggering right here. 80% of all the pain meds, the opioids, pain meds in the world are taken in by the United States. All the ones in the world taken in by the United States. That's a huge number, right? It's unbelievable. The next thing is we're 5% of the world. Isn't that crazy? So we're 5% of the world taking in 80% of the meds. It makes me mad. I'm kind of laughing, but it makes me upset that that's the route that we go. And it gets worse when I go through these more. How much do you think we spend on healthcare a year? $4.9 trillion, right? $4.9 trillion. We have the most doctors, the most resources, the most everything, right? But it all goes to the big pharma type of deal, right? All goes straight there. Oh, yeah. I'm not loud enough. Okay, fine. I'm loud enough for you. You're right in front of me, right? Is this better? Okay, good. So where was I? So yeah, we have the most resources than anybody, any country in the world. But why are we just feeding everybody medication? The stats don't lie. 5% of the world take in 80% of the pain meds. We spend $4.9 trillion on healthcare. And here's the deal. I bet a lot of you didn't know this. So, you always see those commercials on TV, and it's could cause death, suicidal thoughts, all these horrible things, right? And they always have somebody running on the beach while they're saying the worst things, or they're at a cookout handing food off, something like that, right? That's a very common thing. You see the Lyrica, gabapentin commercials, all of that, right? They have commercials where they last just it'll be a minute and a half commercial. I had it on one of my other PowerPoints where a minute of the minute and a half commercial was only side effects, right? So the fact that they can do that, did you know the United States us and New Zealand are the only two countries in the world where you can actually advertise on TV medications? That's not legal anywhere else in the world. It's so normal to us because we see it all the time, right? We see it every day. If you turn the TV on, you're going to see a drug commercial. So they're going directly to the consumer and saying, ask your doctor about this medication, and then a lot of times you don't realize the side effects and things that can go with it, right? Okay, so when treating acute conditions like heart attack, stroke, U.S. is the best. Okay, we're the best in the world at handling those type of conditions, keeping you alive whenever something dire, emergency is happening. Okay, but treating chronic conditions, we're not good. The arthritis, diabetes, chronic heart disease, lung issues, we're not very good at in the U.S. It's because of the way that the healthcare route goes. Anybody want to guess in the top 100 at treating chronic conditions, where does the U.S. rank? 1 being we're the best, 100 meaning we're the worst in the top 100. Yeah, we're pretty much, but not very good. Anybody else? Not good, right? 69. So the United States ranked in at 69. Yeah, it was the other way on the scale. 69th, but I get what you're saying. It's not good. Yeah. 69th. So to put that in perspective, treating chronic conditions, who was better? Okay, Costa Rica was better. Jamaica was better. Egypt was better. Iran was better. All of these countries did better in the statistics for treating chronic conditions. So then I'm going to go full circle. 5% of the world takes 80% of the meds, and we have the most resources in the world, but we're 69th in chronic conditions. We agree that's a direct correlation. That what we're doing is not working. The traditional healthcare route is not working, right? So like I said, I'm going to go over all your options so you can make an educated decision on what's best for you, right? I want to make sure you're aware of everything so we can go from there. So, who here's just so I get a gauge of the room on what kind of ailments we have. Who's knee pain patients potentially? Who are we at? Knee pain. What about low back pain? Low back, not too much low back. Okay, a couple. Shoulder pain, if you can lift your arm up. Down here. Yeah, I was one of those too. So, okay, and hip pain. Okay. So it doesn't matter whether it's shoulder pain, hip pain, back pain, knee pain, whatever, right? First thing that you do whenever you have those pains, what do you typically do first? There you go. So you try to manage it on your own. I got you. You try to manage it on your own. That's the point right there, right? So you might do some different herbs. If you like the natural route, which is awesome. You might do some ibuprofen. You might do some Tylenol. You might do icy hot, Bengay, something like that, right? So somebody's going to try to manage it on their own. Maybe you do ice or heat, right? That's the route. And then after a while, you're saying, well, this knee is still killing me. I thought it'd go away because in the past, I just did all this. I did the ibuprofen for a week, and it goes away, and I'm good to go, right? But this time, it's not going away.
So, you know, a lot of you are nodding your head, you've been in that position. So then the next step is you're going to go to your doctor probably, right? You go to your general practitioner, whoever you go to, okay? Anybody know typically what they do from there? Drugs? X-ray. They'll do some diagnostics, right? Correct. So they'll do some diagnostics, whatever kind of imaging, blood work, whatever they need to do to determine what's causing the issue. And then from there, they're going to typically give you maybe some pain meds, right? They might give you some meloxicam, you know, for anti-inflammatory. They might give you Flexeril for muscle spasms, those type of things, right? So pain meds, you know, we know those don't fix the problem, right? Another route they might go is they might give you steroid injections. Anybody been down that route? Yeah. You know, steroids aren't good for you, right? And I get it. You're in a position where you're hurting and you got to do something, right? So I understand that where you're at, but the whole point of me is to educate you on what, you know, that the harms of these steroid injections, right? So steroid injection, it is a fact. This is well-documented facts you can look up. Steroids accelerate arthritis in a joint, okay? They accelerate arthritis. So if you have an arthritic joint, it makes it worse over time, okay? It raises your blood sugar through the roof, okay? So if you're diabetic or you're borderline, that could be a really big deal. It can cause cataracts in as little as 3 injections, okay? Just 3 injections can cause cataracts. It breaks down, it's toxic to your cartilage. So it literally makes you more bone on bone, breaks down your cartilage. Cartilage is like your brake pads. You know, that's what absorbs the shock when you walk. So it can break that down, okay? It weakens your tendon and ligaments, okay? So a lot of times you'll see if anybody watches sports, we'll say like a baseball player, you know, in the early 2000s, a pitcher hurt their arm, they'd say, okay, well, you need a steroid injection because we're going to get the inflammation down artificially, and then you're going to feel better and we get you back out there. Well, what they found is that these people were actually, they were all tearing their, you know, tendons, ligaments, everything, because it weakens the area. So they don't do that anymore, right? And that's pretty telling. There's a reason why you're only allowed to do 3 a year, right? Because they're not good for you. That's why. If they were good for you, they let you do them whenever they wanted. You know, they cause osteoporosis. That's a big one, especially women, because they're more prone to osteoporosis. You know, they had a study that showed up to 8% of bone loss in just 4 months, right? Where it's injected. Okay, so it's not good, right? So steroid injections, they do pain meds, steroid injections. Okay, what next? You know, you do the steroids, and then that's not working, or you don't want the side effects that can go with it over time. Then, you know, what's typically next? They get, yep, cut, surgery. You got it. That's the whole point. The whole reason I'm up here is to keep you away from surgery if physically possible, right? Okay, you can go. Always talk ahead. You're good. Okay, so this is, I want to show an imaging right here, just so you can see. This is a normal knee joint x-ray right here. You can see the spacing throughout. That's your meniscus, cartilage in that area. If you look over on this one, you know, you can see there's not, where it's dark right here, you don't have so much of that on that side, right? That's a degenerative knee. So on the inside, it's more of a bone-on-bone type. Okay, the whole point, another reason why I'm up here talking is it depends on the degree of bone-on-bone. Okay, there's 4 different levels. 1, 2, 3, 4. 4 is the worst. 4 means that it's too far gone, right? The whole point is to get to you where you get before you get to a 4. 1, 2, and 3 is where we work. A 4 is commonly misdiagnosed. I would say people that have been told they're 4s, I'd say 95% are not quite there, right? That's just how it is, right? And you can see on imaging, right? 4 means there's no joint space, the joint is deformed, there's nothing you can do there, okay? The whole point is to get you before you get to a 4. There's a hip right here as well. This is the one on the right. You can see the one on the right side where it says normal joint space. You can see the spacing. On the far right, you can see where it's darker white, if you will. It's more sclerotic. That's arthritic. That's a bone-on-bone. Okay. This is piggybacking on what I just said. Dr. Ali says steroids aren't safe like they thought. They accelerate arthritis, lead to joint replacement surgeries, and they're toxic for the cartilage. So basically what I just told you. Okay, this was interesting. I put this on here because it shows the, really how quickly they have the potential to degenerate your joints. This is imaging right here. There's spacing right here. You can see where it's darker. That's the space in a hip joint. They did an injection, a steroid injection. 7 weeks later, you can see decreased spacing. The reason why that's so significant is that you don't see little changes in that amount of time on imaging. It takes a much bigger amount of change. It takes a very big change in order to see it in that amount of time. So that just shows it completely can obliterate the joints. Okay, for my back pain people. So I thought this one was pretty staggering. Anybody know somebody who had a surgery, a back surgery, like a fusion or a neck surgery, a fusion, and they had to get another one? You've heard of that, right? Most people have seen where you had to get 3, 4, 5. Now they can't really move well. I'll go through all that. But they had a study. This is a Spine Research Foundation, guys. Spine Research Foundation did a study, and they were checking prognosis and outcomes 2 years after low back fusions, okay? They were checking, basically they were checking patient satisfactory rate. 2 years out, there was a 35% satisfactory rate in low back fusions in the young, slim, and athletic. This is patient reporting. This is thousands of people, right? We're not talking 6 people didn't have a good outcome. We're talking thousands, right? All done by the Spine Research Foundation. So it's, if anybody said, hey, I have a 35% success rate for you, you're walking that way, right? But that's the things that I just want to make you aware of, right? These things, and I'll tell you why. Can we go to the next one, please? So here's a fusion right here where it's real white. That's your hardware. That's in the spine. Let me see if I can get over here. I want to pull this thing. That's the fusion right there, right? So see how it's basically what it's doing, what it sounds like. It's fusing the area. It's not moving. We're not going anywhere, right? It's holding it in place. It's anchoring it in. Problem is when you move forward, back, side to side, this isn't going to move because it's doing what it's there for. But guess what? Above and below are going to start to move too much. It's called alteration of motion segment integrity, too much motion. So when an area, any joint moves too much, then you get you get arthritis and you get disc problems, right? So then now, okay, I have those symptoms again that I had before, and what do you think they do? They go, whoop, we're going to fuse there, whoop, fixed, and then it's just a never-ending problem. This one had multiple, right? So that's why a lot of times you hear that. I had somebody the other day, I was doing this talking about that. They said, oh, that happened to my brother, and what happened to me is when they drilled in, I was osteoporotic, and it crumbled around it, right? So then they couldn't even get it in, but now they had a whole mess in there that they had to go in there and try to fix, right? One of the most common long-term failure of a joint replacement surgery is the bone crumbling around it. Because as you get older, your bones, they don't get stronger typically over time, right? But the titanium, whatever they're putting in there, it's going to stay strong. So when they drill into there, your bones get more brittle, but it's not getting weaker. So that's the problem. Then you have a mess. So there's a lot of side effects like blood clots, nerve damage, infection. We had somebody come in today and they said, they were at a huge risk of blood clots, so that's why they weren't getting surgery, right? Because those things, they're very real. Nobody thinks it happens to them. You go next. Okay, so that's basically on one side of medicine, that's what you're up against, right? And a lot of you have probably been through a lot of that, right? And you're here because you're looking for a solution. You're just looking for that. You want the information so you can make the right decision. So I'm going to talk to you about joint rejuvenation using biologics to naturally heal the body without medication, surgery, and there's no downtime either, okay? I'll go through each product one by one. So A2M is alpha-2 macroglobulin, okay? Alpha-2 macroglobulin. Significance of this one is, remember in the beginning, I said arthritis or cartilage breakdown, disc problems, they're caused by these proteases that eat up your joint, the Pac-Man that I talked about, right? They eat up your joint. So over time, when it keeps eating up your joint, if your A2M is not, it's a molecule in your body that doesn't have a high enough dose as you get older. So what we do is we take it at a high concentration and inject it right where it needs to go. Its job is it gets rid of proteases. So basically, The Pac-Man that's eating your joints up, it gets rid of the Pac-Man. It gets rid of the cause of degeneration in a joint. There's a reason why you don't see young people 18 years old with serious arthritis or degeneration, because all these molecules and stem cells are working how they're supposed to, right? You go two more. There you go. Stem cells. Okay, the big one. Everybody. Has anybody done any homework on stem cells? You know a little something about it? Yeah, you too. Yeah, we talked before. So, stem cells. What are they? Okay, they're the cells in your body that differentiate into all the different type of cells, right? They're the guide that says, okay, we need to replicate into cartilage, bone, muscle, literally every cell in your body. You're made up of stem cells. They're the healers of your body. Okay. As you get older, like we said, they decrease with age. So you think of a little kid, you think of like a 6-year-old. If they get a cut or they break their arm or something like that, they heal so fast, right? Because they have a high amount of stem cells circulating throughout their body to help go in, say there's a problem here, we're going to help regenerate it and fix it. Now, somebody who's 100 years old, they get a cut, break their arm. Well, it's gonna heal real slow, and there's a lot of complications that can happen because they have a lower amount of stem cells. So if you get stem cells, harvest them and put them directly where the damage is, the body will do what it's naturally designed to do. Your body wants to heal itself, right? It wants to. It just doesn't always have the right material as you get older. When people are in pain, if you had pain for longer than 3 months, it's considered chronic condition. That's by definition. You have a chronic condition. Basically what that means is your body's been through its checklist. It did everything. Okay, I'm trying to heal the area. This didn't work. Okay, let's try this. And it went through. And at that time point, it's done everything it can do. It doesn't have another option. It doesn't know what else to do. So the problem is pain's a good thing initially. It sends that paracrine signal saying, hey, come to the shoulder, fix the problem. It's in the stem cells, right? But then if it's not able to do it, it's not going to stop sending that paracrine pain signal because your body wants to try to fix it. So if it doesn't have the material, it's just going to keep hurting. And that's the problem. So when you put stem cells, introduce it right where the problem is, your body it eats it up and says thank you and basically and regenerates and heals itself, right? Just like when you're younger. So this is cool right here. Mayo Clinic. Everybody's heard of that? Heard of them? So here's the deal. Mayo Clinic. All right. They have thousands of studies on osteoarthritis, any type of degenerative condition, spinal cord issues, type 1 diabetes, type 2 diabetes as well, Parkinson's, stroke, heart disease. The reason I put this on there was to kind of demonstrate the healing capabilities of stem cells. Spinal cord issues. Anybody seen on Good Morning America? They had that segment where they had the paralyzed man. Did anybody see when he did stem cell injections? Okay, I said this the other day, and there was a 60 Minutes that came out recently. I haven't seen that yet, so I don't know if any of y'all have seen it. But basically, to sum it up, he was a surfer out in California. He had a neck injury, and he was paralyzed neck down, right? He couldn't move, anything, right? It had been over a year, completely plateaued, was not getting any better, no motion at all, right? Mayo Clinic reached out to him. They said, hey, we want to inject stem cells into your spinal cord to help see if we can get a result, regenerate the area, see if we can help you. He said, sure, do whatever you want. His quality of life is completely shot, as you can imagine. So at that point, he went in, did it. Within weeks, he was moving. Within months, he was walking. Isn't that crazy? And I'm not talking 10 months. I'm talking 2, 3. It's good. You can look it up. Paralyzed Man Walks, Good Morning America. And apparently there's a 60 Minutes that I haven't watched yet. But it's very, very interesting. So the point of me saying that is, of course, that's amazing. But the spinal cord wasn't just completely severed. There was obviously damage to the area. Over a year where it wasn't fixing itself. So they introduced stem cells to say, hey, you go in there, try to fix it, put a high concentration in that area. And the body went in there and fixed the problem, right? It just needed that extra push. It didn't have the material to fix it, right? They also had studies with diabetes. Commonly diabetics, and now we don't treat this, but I'm just showing you the potentials here. Diabetics, they typically will have pancreatic issues as it goes on over time. That's a common thing that can happen, right? They did IVs, and they proved that they had a 50% increase in pancreatic function, right? Your body just needs the material. And that's the point. We focus in the regenerative realm, and we treat conditions caused by diabetes now. So, and I'll go into it a little bit, but neuropathy, common thing we see, burning, numbness, tingling in the hands and feet. I'll go into it now. So basically, burning, numbness, tingling in the hands and feet. Commonly, the prescription that when you go to your doctor, they're gonna write you gabapentin, right? Take the gabapentin. Next step, if that doesn't work, they're gonna give you Lyrica, right? If that didn't work, they're gonna do a combo. If that doesn't work, they're gonna just shrug their shoulders, right? The problem with those medications, they do not fix it. It is a fact. What they do is they actually slow down brain activity to the area to try to disconnect that pain pattern in your hands or feet or wherever you're feeling it. Okay, so that's why people who take it, if anybody's taken it before, they can kind of make you feel funny in the head or just kind of off balance and just very strange, right? So that's the problem. We actually work to reverse neuropathy symptoms as well naturally. Like I said, we don't do medication, surgery, anything like that. Okay, so a little bit tidbit on that. Okay, PRP, platelet-rich plasma. Okay, that comes from the blood. Okay, it's a blood draw. You spin it in a centrifuge to separate the blood layers. Okay, there's the separate layers, and it's the plasma is up top. We're separating the plasma, which has the platelets and growth factors. You take it in a high concentration, and you inject it directly where it needs to go so the body can regenerate. This is commonly used with people with any type of rotator cuff injuries, any type of muscular issue, tendon, ligament. If you have a labral tear, if you have LCL, PCL, ACL tear in the knee, that type of deal. Commonly also with people with carpal tunnel, cubital tunnel, these type. They're also can help a lot with arthritis as well, but it gets blood flow to the hard to reach blood flow areas because blood flow is life, right? Okay, this is a patient that came into our clinic. I thought this was amazing, very cool. So let's see. You see right in here, I can see right here, there's no spacing right here, as you can see on this side. See how that's darker right here? That's where the space is, okay? So this guy, let's set the table for, a little bit about him. 68 years old, overweight, diabetic, had open heart surgery, in very poor health, lung issues, very poor health. He went to his doctor, a lot of knee pain. He said, I need to do a knee replacement on you, but I'm not going to. I can't put you under general anesthesia. You might not wake up. I can't do that. So he said, you're going to have to live with it. Couldn't do steroid injections either because his blood sugar was so high, right? Because he was pretty bad diabetic. So he saw us on TV actually, came in, and 7 months later, right here, you can see the spacing in that joint. It's the borders are better, they're more defined. Looks a heck of a lot better, right? What's in that space is cartilage in the meniscus. Isn't that cool? They did a study, PubMed study. You got to be careful. Any researchers, you got to be careful about your studies. Make sure they're the good ones, right? So they had a PubMed study, and it was showing injections into the cartilage in a knee. They did an MRI before, and then they did 24 weeks later. They did another MRI after stem cell injections into the cartilage. They showed significant cartilage growth in that area. And if you know anything about that, they don't just say significant. They don't exaggerate, right? This has got to be done right. So I thought that was really cool. And then to have them come in the clinic and you can actually see there. So pretty cool stuff. This is a patient that came in. So backstory on her, she had knee pain, told she needed knee replacement, whole bunch of pain. Was on her last option. So she saw us, came in. She was having a lot of trouble squatting down. So when she would squat, you'll see in the video, she was real hesitant when we asked her to squat because it used to hurt so much. And then you can see she was surprised to see how much it didn't hurt. So I'll let her talk.
I couldn't do anything, not even stairs. Yeah. And walking long distance was really bad. Even after the first time, I saw a difference.
So you were up and about, on your feet, a lot. Any pain in your knees at all?
No.
No, nothing?
No.
Over the last 2 weeks or 4 weeks or so, any trouble doing anything?
No.
Okay.
No.
Have you squatted?
No.
Okay.
I haven't.
You haven't tried that yet?
No.
Okay.
No.
And I want you to kind of like sitting in the chair, I want you to go and go down and squat, okay? But don't sit on the chair.
Don't sit on the chair.
Yes.
Okay. Okay.
And up. Any pain?
No.
Are you able to squat down a little bit further?
No.
That's okay. Any pain?
Oh, no.
No pain at all with that?
No.
Okay.
It works. Even my daughter, when she saw me, she was skeptical at the first time I told her about it.
Mhm.
But then when she saw me, she's like, Mom, I see a difference. You can walk. And I'm like, see, I told you.
Really cool, huh? So I always go back
It
to
was a temp-
why do you want to feel better, right? That's the biggest thing. You know, it's all about your why. One of the biggest things when we get patients in, what's that? How old was she? You know do we know how old she was? But I'm not sure exactly. Yeah. Yeah, I don't know how her age, but I'll tell you this because this actually came up the other day. We've treated at this clinic here, we've treated patients 103. So our average, I would say, what do you say, 70? Yeah. 70 years old. So, you know, people typically, they come to us when they're at a position. There's two type of people that come to us. Patient who knows the typical route of medicine, they don't want to do that, so they're trying to get ahead of it. Or somebody who's in that position where they're told they need surgery, nothing else is working, you know, and they don't want to get surgery, right? That's the most common people that we see. But like I was saying, it's all about quality of life. So when a patient comes in, we go over goals. That's very important to me. It's really important to Dr. Sun as well, because we can't just be turning the wheels. We have to say, for instance, we had a patient today. She wanted to go in November. She needed to go to Japan. She had to go. She goes twice a year, right? So I said, okay, that's the goal. We got to get you to go to Japan. She takes 17,000 steps, and when she went last time, and she couldn't do it. That's her normal amount. She couldn't do it, so it really bothered her because she went with her family. These type of things is what we need to know, so we can help you achieve your goal, right? All about quality of life. And you can skip that video there. So next step, consult. Let's talk about what this entails. So you come in, we do a consultation, of course. We talk to you, get all the information on what's going on, all the nitty-gritty details. From there, we do in goal setting, of course. We do an orthopedic and or neurological evaluation to see what the issue is. Any imaging that you do have, we do ask to please bring. Any type of information, any medical record, please bring it in, okay? So we can have the full picture. From that point, if we need more, we'll get it, right? If we have everything we need, then we'll know if you're a good candidate or not. Okay, like I was saying earlier, not everybody's a good candidate. That's the truth, you know? So we have to see, we get it all together, and if you are, we have the potential to really change your life, change the whole trajectory, right? And if you're not, we push you where you need to go, right? So if you just need something else, that's where you go, right? So it's a win either way, right? You get the care that you need either way. So that's very important to us. If you're listening in or you're here, of course, it's a $47 exam. It's normally $87. Okay, so you schedule today, you get a $47 exam. Okay, so you get a really good deal there. We have the option to do both, donor and from the patient as well. Yes, correct. The same we were talking. It depends on the case that you're treating. It really depends. That's why it's a consult. But I tell you, we do both. So whatever is necessary, we can do. Oh yeah, of course. Oh yeah, sir. Okay. So without further ado, any other questions? Any questions? I'll answer some questions and then I'll come around and get you guys scheduled. Yes, ma'am. Good question. So what would make a person not a good candidate? Okay, if they're a grade 4 degeneration, the joint's completely obliterated, there's malformation of the joint, maybe there's a congenital abnormality, that's somebody who's not a good candidate. If you've already had a hardware, now if you've had a fusion, we could potentially help you as well, but I'm talking about a knee replacement. We can't inject the metal, unfortunately, right? So those are different things. If somebody has active cancer, they're not a good candidate because what this does is help regenerate and regrow, right? So we don't want that. So those are the most common things right there. Good question. Mhm. See that? Mhm. Yes, absolutely. Absolutely. You can get her in and we can do a consult to one of our doctors. Oh, yes, ma'am. How many shots do you normally need? That's variable because here's the thing. Everybody's so different, so it's hard to speculate until we see you because somebody might just need, a bone marrow stem cell or a different type. Somebody might need a combination of that and then PRP. Somebody might need A2M. And the dosage is different on everybody as well. So it really depends. Somebody might be one, some might be multiple. So, but once we do an exam, a thorough exam, I promise we go over all that, and we'll know the nitty-gritty details on everything. Depends. It depends on exactly those factors. Most economical. Oh, I mean, we have packages. It could be monthly payments, typically $100. It could be go up way more than that. It just depends, It just depends on what you're getting done. But yeah, look, we have affordable payments for just about everybody. Most of the people we see are retired or on disability. So once we get all the information, then we can check you out. There's none covered by insurance. Well, insurance is going to go the typical route where it's the steroids and ultimately leading up to surgery. In my opinion, I have to say in my opinion, it's a big pharma type of deal, right? For instance, 80% of the pain meds are taken in by us, but it's clearly not working because of, we're not good at treating chronic conditions here, right? So hopes that'll change. It will one day, but right now we're not there. I am not. We're multidisciplinary. We have MDs, we have chiropractors, we have physical therapists, we have every type. Mm-hmm. 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 To somebody else? Yes, correct. No, we don't know because there's too many chances of rejection. Most people do, and if that's not an option, there's donor routes. Yes, sir. Good question. Yes, I'll get them to give all that every island. There's some there always, and then some they come in and out. This is the main location, though. This is the headquarters, if you will, on this island. Oh, glad you brought that up. Yes, so we do. So wherever you put it, because of the nature of what they are, they're the healers of the body. They help regenerate, right? Wherever you put it, they can help with skin. If you go topically on the face, if you microneedle them into the skin, helps with anti-aging, reducing wrinkles, increasing elasticity to the area. We do the hair. If you inject into the scalp, it can stimulate the follicles to push more hairs out. So yeah, those are big things we do. Yeah. Thank you. Nope, no problem. No problem. Glad you brought it up. Yes. Oh, real quick, I'm sorry. Because I want to hear what you have to say, but because of HIPAA compliance, legally I'm not allowed to, in a group setting, I can't hear the details, especially we're on air too. But in a group setting, I can't go over the details. I can come talk to you one-on-one in a little bit. Okay? Yeah, I'll come talk to you. Sorry, I didn't mean to cut you off, but that's, I got to do it. Okay? Oh. Got that question yesterday. Yeah, so we don't do that. That's not one of our focuses. There is a lot of research and studies on the eyes. They're doing it. They're having very good success with open-angle glaucoma, and then any type of vascular issues because they can cause angiogenesis, which is new blood vessel formation. So yes, there is work on that, but that's not our focus. Good question. Yes, sir. The success rate's going to determine completely on where you're at, right? It just depends. That's another thing that's covered in there. Side effects, really, that's one of the beautiful things about it. Soreness where you injected, like with any type of injection. You know, if of course, anytime you introduce a needle, there's a risk of infection. We never had one, right? But anytime if you get a cut, you can get an infection. There's no different risk than that, right? So those are the big ones I would say. Soreness, yeah. That's a good question. So no, to answer your question, no. They've found a lot of these countries that if you leave the U.S., they're putting ridiculous amounts of stem cells in an area, and they had some studies. Thought it was really interesting because you think, okay, a whole bunch more means better. Not necessarily. They had some studies where they were injecting ridiculous amounts of stem cells cultured into different areas, and they were creating, benign tumors, but they're creating tumors because it was in that, it's overproduction of cells, right? So that's the problem. We don't do that. We don't do any of that stuff. We don't touch that. We can get some. Absolutely. 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 And then ours is mesenchymal. Oh, gone. Mesenchymal, and that's one with the most research. But the beautiful thing is we can get you some stuff, and with AI now and everything, you can look everything up, and it gives you quick, good answers too. So we'll get you some info. Hmm? Yes, ma'am. Yes, ma'am. Right here, right in the hip. This is where the most amount in your body are. That's the most abundant. So she asked if it's painful. How it works is we numb the area up very well. The bone doesn't have nerve endings. I'd say 95% of patients describe it as a lot of pressure, not pain. It's not like a biopsy where those can be really painful, if anybody's heard of those. It's not like that, okay? If this tells you anything, you walk in, you walk out, you're sore for 1 to 3 days, typically. Patients are usually talking to us while we're doing it. No biggie. They feel pressure, not pain. Okay, that's the typical route. I'm not going to sit here and say there's absolutely zero. Everybody's a little different, but there's not excruciating. That's for sure. Depends on how many joints and how many we need. I know you need. It depends. It depends. A lot of factors. But all that can be covered when we come in. And we'll know. I'll tell you all. We'll tell you, whoever you see, we'll tell you all the details. Yes. Okay, cool. If you're asking me, it depends on of course, pain's subjective. I would say a 1 or 2. And then one of the guys at the station, he wasn't here today. He actually had it done, and he spoke last time we did this. He's like, man, I thought it was going to hurt. That's usually the reaction you get, honestly. I would say, the staff here, they'll tell you the same thing. People, they think, oh, it's going to hurt. They go, why didn't that didn't hurt? I thought that was going to hurt a lot. Very low, very low. We have people. 3 days. 3 days, exactly. Even if we take a large amount, and the reason why is because it's so rich in stem cells. Because when in the bone marrow, it's not just stem cells. There's red blood cells. There's a lot of different things, right? There's so many stem cells in that area that it only takes 3 days. And whenever we take it out, we filter it, we centrifuge it twice to separate the layers, so we get the high concentration of the cells. Hmm? Good question. How long? Typically 20, 30, no, not 20, 30, 35 minutes after it processes. Yes, sir. Did I have a question? You can treat multiple areas. Yes, you can treat multiple areas in one session. Lots, probably up to 7 or 8. So you could, if you have 2, 3, there's no problem. Correct. Correct, and it all on one extraction. It just depends on the volume that we take out, and that's yep, no problem. Yes, ma'am. Exactly. So that's why we're very selective on who we pick. Because look, our reputation's everything, right? And we've been here for a while, and we want to make sure we keep it. So if you're not somebody who we think is going to respond well, we don't take you. So that's everybody doesn't, and that's why we're pretty picky. But we'll tell you if we, of course, we'll let you know if you're somebody who we think is going to respond very well. And if you're not, we'll tell you. Knee versus back, both of them are really, those are the top two things we see, to be honest with you. I don't have a certain number because we're not conducting studies on that aspect right now. I did come across a study one time. It showed an 82% success rate on satisfactory rate. Again, we didn't conduct that. That's not us, but we do a lot more than what the study did. So the hopes is much, much higher. Okay. Oh. No, great. That's a great thing. Is there any medications or anything that you have to take? This is all natural. That's the beautiful thing about it. There's no recourse or repercussions of doing it down the road. I'm glad you brought that up. So, somebody, yes, sir.
Yeah, you said insurance doesn't cover.
Mm-hmm.
What is the range of the cost to do a knee?
To a knee, all in, and if we're talking monthly payments, 100 to 400, in a monthly payment, I would say, if I had to give you something right now.
That's a monthly
Yeah,
payment.
yeah, total, it could be,
5 grand.
it could be $2,000 to 8, I would say, 2 to 8, somewhere in there. It varies a lot because so many different things. I wish I could just give you, hey, this is what it is, but it's, if I tell you one thing, you come in, it might be completely different. You know what I'm saying? So.
One of your ads said something about the cost is generally less than the copay for surgery.
Mm-hmm. For the exam, are we talking? Oh, the copay for surgery. That's correct. I'm sorry, I misinterpreted. That's correct. Sometimes those surgeries can be very expensive. If anybody's had them, if you're that's the truth. If you're VA or you have the right kind, right? But again, the repercussions that could happen, right? So.
You have both knees are going on. You can do both at the same time.
Yes, sir. Yes, sir.
Use stem cells from corded blood, or is it always just from the?
It's from the bone marrow, and then there's also options for umbilical cord.
So that is an option.
Correct.
How much more is that option?
It's not anymore.
Maybe.
How much more price-wise? It's not anymore. It just depends on which one we would need to use. It's not a different price.
And is that native stem cells, or is it?
Is that what?
Is that native stem cells, or is it regenerated multiple times?
Oh, are you asking from a donor or?
Yeah, like the corded stem cells. Is it the native stem cells, meaning it's never been, like you said, in a petri dish?
Oh, yes, of course, yes, correct. It's never been a petri dish. We don't do any manipulation to the cells, correct. Yeah. Yeah. Why would it be better or worse, right? Depends on the severity. If it's incredibly severe, then we typically like to go that route. We like, if it's not, we much prefer to do it from you because there's 0% chance of rejection. So we know that there's not a chance. We do. She asked if there was peptides that we use, and yes, we do peptides. Whether it's any of a lot of different types. There's, of course, if you're familiar with them, there's thousands of them. So they're great, absolutely. Correct. Oh, yes, sir. Potentially depends on what we're trying to accomplish. Potentially, it depends on what we're trying to accomplish. If they have a muscular atrophy type of condition, You know, if it's something like multiple sclerosis, we're not going to sit here. We're not going to treat the multiple sclerosis. Now there are studies, but that's not, you know, that's not approved yet, right? Mm-hmm. Yeah, if it's pain related, that type of deal. But for the actual atrophy, then no. Potentially, yes. Possible candidate, absolutely. Okay, and I'll take.
One session. What is one session? Withdrawal, centrifuge, and re-injection? And time-wise for one session?
Timeline probably 30 minutes or so, and that's exactly what you just said. So if we're talking about bone marrow stem cell, then yes, we withdraw, filter, centrifuge twice, and then inject. You got it. All right. So look, what I'll do from here is I'll get them. They'll come get you scheduled. Actually, you can probably best if y'all come up over here. Oh, in the back with Jessica, everybody. They have their hands up. They get you scheduled. Like I said, you're here today, so it's $47. So take advantage of that. It's usually $87. So you're getting a heck of a lot of information for that amount. So you might as well come get it, see where we're at, and then you make your decision from there. Fair enough?
So we have to go to the office at Rectania.
Correct. And they'll give everybody the addresses.
I called them already.
Oh, you did? Okay, perfect. All right. And I'll come talk to you too. We'll go through that. All right, y'all have a good one. Hope y'all enjoyed it. Okay?